Hi everyone. Today in this video we are going to discuss about glipizide. What is this drug glipizide? The prefix gli indicates this is one of the drug related to oral hypoglycemic agents. And this glipizide chemically belongs to sulfonyl ureas, and particularly within the sulfonyl urea category, two generations are there, first generation as well as second generation. Among these, glipizide is a second generation sulfonyl urea derivative. We have few of the other drugs within this category such as glibenclamide and glimepiride. All these drugs are second generation sulfonyl urea derivatives. So these drugs act by increasing the insulin release. They mainly act on the beta cells and they promote the release of insulin. That's why these drugs are useful in the treatment of type II diabetes mellitus. Apart from increasing the insulin release, they also control the glucose levels by other mechanisms. So today in this video, we are going to discuss about this glipizide, how this drug acts, what are the precautions, side effects, interactions, and the doses available for this drug. Even this drug is going to increase the insulin release, but still it should not be used in the type 1 diabetes mellitus, which is associated with lack of insulin and insulin resistance. And this drug is also not preferred in the patients with diabetic ketoacidosis. So only in the type 2 diabetes who are not suffering with the ketoacidosis, this glipizide can be used. What is the structure of glipizide? So this is the structure of glipizide, and here we can observe sulfonyl urea moiety. Let us give the numbering to this urea initially. So we can give the first numbering to this nitrogen because it is attached with the cyclohexyl ring, which is alphabetically comes first. So this is second one and is third one. So first position cyclohexyl ring is there and third position sulfonyl group is present, which is further attached with the phenyl ring. So we can write this as 3-phenyl sulfonyl urea with first position cyclohexyl ring. So these are the structural features of glipizide. Now let us see how this drug acts. Insulin is released from the beta cells of the pancreas. For the release of insulin, glucose is the main signal. This glucose is going to be taken to the beta cells through the GLUT2 receptors. When this glucose enters into the beta cells, it undergoes glycolysis. So the first step is the conversion of glucose into glucose-6-phosphate. So this step is mediated by one of the phosphorylating enzyme, hexokinase. Then this glucose-6-phosphate can undergo glycolysis and finally it can release the ATP. ATP is one of the important signal for release of insulin from the beta cells. The target for this ATP is the voltage-gated potassium channels. So potassium ions can go out of the beta cells through these voltage-gated potassium channels, resulting in hyperpolarization. But here ATP binds to these ATP-sensitive potassium channels, thereby it inhibits the activity of these potassium channels. So when this potassium is not going outside, it promotes the entry of calcium. Now the calcium can enter into the beta cells, which promotes the exocytosis such that insulin can be released from the beta cells. In this way, the elevated levels of glucose within the blood can stimulate the release of insulin from the beta cells. Now here glipizide acts just like ATP. This glipizide can bind to sulfonyl urea receptors which are associated with these voltage-gated potassium channels. When this glipizide binds to these sulfonyl urea receptors, it results in the inhibition of voltage-gated potassium channels, which promotes the release of insulin from the beta cells. In this way, glipizide acts as secretagogue and it increases the insulin release. Glipizide can also show the other activities apart from the insulin release. It can act on the liver, which is going to increase the hepatic glucose production. So glipizide is going to inhibit the hepatic glucose production. Similarly, it also acts on the adipose tissue and it inhibits the lipolysis. And finally, it acts on the muscle. It increases the glucose uptake into the muscle. In this way, glipizide controls the glucose levels by release of the insulin as well as it promotes the actions of the insulin. What are the precautions? One of the important precautions of glipizide is that this drug can induce hemolytic anemia in the patients who are having the deficiency of glucose-6-phosphate dehydrogenase enzyme. This is one of the important enzymes for production of NADPH molecules which are required to eliminate peroxide free radicals. So when this enzyme is deficient, in such patients there may be an increased hemolysis leading to hemolytic anemia. So within the erythrocytes, the hydrogen peroxide should be eliminated as water molecule plus half molecule of oxygen. This reaction is carried by glutathione, which is acting like antioxidant. This glutathione undergoes oxidation such that it produces the disulfide bridge of the glutathione, and this reaction is mediated by one of the enzyme, glutathione peroxidase enzyme. Now this disulfide form of the glutathione is going to be reactivated to glutathione, and this step is mediated by one of the cofactor NADPH. This NADPH along with H plus ion, it can be converted into NADP plus, where the two hydrogens are supplied to this disulfide bridge and glutathione is going to be reactivated, and this step is mediated by another enzyme, glutathione reductase. In this way, NADPH is an important factor for removal of peroxides from the erythrocytes, but this NADPH can be obtained from the NADP plus through the glucose. Now glucose is converted to glucose-6-phosphate. This glucose-6-phosphate can be converted into 6-phosphogluconate by the enzyme glucose-6-phosphate dehydrogenase enzyme. So this enzyme is required to produce the NADPH, which promotes the activity of glutathione as free radical scavenger. Now in the patients who are having the deficiency of glucose-6-phosphate dehydrogenase enzyme, it results in the inhibition of free radical scavenging activity, which increase the number of free radicals leading to hemolysis and hemolytic anemia. Similarly, another important precaution is that glipizide is going to increase the insulin secretion, and when insulin is released into the blood, decrease the glucose levels resulting in the hypoglycemia. This is one of the common problem with most of these oral hypoglycemic agents, and this is more observed with sulfonyl ureas because they are going to increase the insulin secretion. And if the patient is having other conditions like malnutrition, otherwise hepatic impairment, where it results in the decreased metabolism of glipizide, or adrenal insufficiency, all this can promote the hypoglycemia produced by glipizide, resulting in the severe hypoglycemia, some shakiness, tremors, and falling sensation in the patients. Among the sulfonyl ureas, tolbutamide is the first generation sulfonyl urea. This drug is withdrawn from the market because this drug is going to increase the cardiovascular mortality. Even the exact mechanism is not clear. This tolbutamide is going to target the ATP-sensitive potassium channels present on the heart. We know that these drugs are going to block the ATP-sensitive potassium channels present on the pancreatic beta cells, but at the same time they are also having some affinity on ATP-sensitive potassium channels present on the heart. So tolbutamide can block these channels, thereby it can increase the cardiovascular mortality. Just like the tolbutamide, here glipizide, which is a second generation sulfonyl urea, also shows some similar activity, so it can also increase the risk of cardiovascular mortality. This can be observed after long-term treatment greater than 5 to 10 years. Similarly, if you have the conditions like fever, surgery, infection, trauma, all these are the stressful conditions. So these stress-inducing conditions may result in the loss of glycemic control. In such conditions, glipizide is somewhat inactive, so it should not be used, and it should be replaced with the insulin. What are the drug interactions? If you have the drugs like miconazole, fluconazole, these drugs are the azole antifungals. They can inhibit the metabolism of glipizide. So these drugs, when they are given along with the glipizide, they can increase the levels of glipizide, resulting in severe hypoglycemia. So whenever azole antifungals are co-administered with the glipizide, the dose should be adjusted in order to control the hypoglycemia. Similarly, many of the drugs interact with glipizide. For example, NSAIDs, salicylates, sulfonamides, MAO inhibitors, even probenecid, all these drugs can interact with the glipizide either at the protein binding sites or at the metabolism. Thereby, these drugs can also increase the glipizide levels within the plasma, resulting in severe hypoglycemia. So when these drugs are co-administered with glipizide for chronic period, the dose should be adjusted in order to control the hypoglycemia. Similarly, few of the drug interactions can be observed at the absorption phase. Cholecalciferol is one of the bile acid binding resin. Similarly, other drugs like cholestyramine, cholestyramine are bile acid binding resins, which are macromolecules. So when they are given along with the glipizide, they can form a complex with the glipizide. Now these glipizide molecules can form insoluble complex with these bile acid binding resins, and this complex is non-absorbable, so that the absorption of glipizide is going to be inhibited. That's why whenever these bile acid binding resins are given, glipizide should be administered 4 hours before in order to prevent this interaction at absorption phase. What are the side effects? One of the important actions of glipizide is the stimulation of beta cells. So when these beta cells are stimulated, it increases the insulin release. But apart from its action on beta cells, glipizide can also act on the other pancreatic cells. It can inhibit the alpha cells which are releasing the glucagon. So glipizide can decrease the release of glucagon, thereby it can control the glucose levels. And it can also promote the delta cells, thereby it can increase the somatostatin release. But among these, the action of glipizide on beta cells is mainly responsible for control of glucose levels within the body. The important side effects of glipizide mainly include dizziness, weakness, headache, and nervousness, tremors, even blurred vision. Most of these side effects are related with hypoglycemic symptoms and hypoglycemia, flatulence, skin rashes. This is another important side effect of glipizide commonly observed with sulfonyl ureas. They can produce skin rashes and hypersensitivity actions, and they can induce urticaria because of sulfonyl urea moiety in their structure. Similarly, it can produce anemia, particularly hemolytic anemia can be produced by this glipizide, and porphyria, disulfiram-like effects such as flushing, hypotension can also be observed with this glipizide. How it is given? Glipizide is available as a tablet as well as extended release tablet. It is available at the different strengths from 2.5 to 10 mg. The dose of glipizide depends on the patient and patient conditions. The initial dose is given at 5 mg once daily. The dose can also be reduced to 2.5 mg according to the patient conditions such as hepatic impairment or renal impairment. And in order to control the glucose levels, the dose can be incremented at a rate of 2.5 to 5 mg such that the dose may be achieved up to 15 mg once daily. This dose should be individualized based on the glucose levels within the patient, and the maximum dose can be up to 40 mg once daily. So that's about this glipizide. Glipizide is a second generation sulfonyl urea derivative. This drug is particularly useful in the treatment of type 2 diabetes mellitus, but this drug is not useful in the type 1 diabetes mellitus as well as in the diabetic ketoacidosis. This drug mainly acts by release of insulin from the beta cells. It blocks the ATP-sensitive potassium channels by acting on the sulfonyl urea receptors. Thereby it inhibits the hyperpolarization, promoting the depolarization and release of the insulin. Since this drug increases the insulin release, it can produce hypoglycemia as one of the important side effects, and because of the sulfonyl urea moiety, this drug can also produce hypersensitive reactions like skin rashes and urticaria in the patients. This drug may produce hemolytic anemia in the patients who are having glucose-6-phosphate dehydrogenase enzyme deficiency, and in few of the stressful conditions such as fever, infection, trauma or surgery. This glipizide may not produce sufficient glycemic control. In such conditions, insulin should be replaced with the glipizide. Azole antifungals like miconazole and fluconazole can increase the levels of glipizide, leading to severe hypoglycemia. Similarly, many of the drugs like NSAIDs, MAO inhibitors, salicylates, sulfonamides, probenecid, all these drugs can increase the levels of glipizide, leading to severe hypoglycemia. Bile acid binding resins can reduce the absorption of this glipizide, so this drug should be given 4 hours before the administration of bile acid binding resins. Dizziness, weakness, nervousness, tremor, hypoglycemia are the important side effects of this glipizide, and it can also produce flatulence, skin rashes, hemolytic anemia and porphyria in the patients. The dose of this drug is individualized. The initial dose is 5 mg once daily, given 30 minutes before the meal, but the dose can be increased up to 15 mg once daily based on the glycemic control in the patients. So that's for today. Hope you have enjoyed this video. If you like this video, please subscribe to our channel, share this video with your friends, post your comments in the comment box. Thank you for watching this video.